regulations that impact the delivery of virtual care. Our research falls into two buckets. The first bucket is traditional policy research, and the second bucket is academic research that is conducted to solve a policy concern. In 2015, CTEL met with the Congressional Budget Office, key committees of jurisdiction, the White House, and the administration. And it was suggested that CTEL conduct research looking at the cost impact of telehealth on Medicare and efforts for CBO to have good quality peer-reviewed academic data to reassess the cost impact of telehealth on the Medicare system. As a refresher, in 2001, Congress brought forth legislation that would expand telehealth reimbursement under Medicare. In order for any spending bill to pass Congress, that needs to have a score by the Congressional Budget Office. And at the time, the CBO did not have accurate enough data to properly score telehealth. So they used two data sets that they had that were really not even focused on cost, and they ended up scoring telehealth 83% higher than it actually cost the federal government. So politically, congressionals couldn't go back to their districts and say, we're not going to offer telehealth. But at the same time, they had to be cognizant of the fact that there was a budget to be balanced. And that was a real key concern in the 2000-2001 timeframe. So what happened is a compromise took place where congressionals came up with the idea that they would purposely suppress utilization to suppress cost. And that would be less impactful on the budget. So the four originating sites that we are all familiar with, which is the geographic restriction, meaning that in order for a doctor to be reimbursed for a patient, that patient has to be physically located in a geographic region that is considered rural by CMS. That's requirement one. Requirement two is that patient has to be physically located at a hospital, clinic, or skilled nursing facility. They cannot be located in their home. Requirement three is that there's provider restrictions. Not all providers are reimbursable under Medicare for telehealth encounters. And the fourth requirement is assuming you've met requirements 1, 2, and 3, you had to find a CPT code that aligned with the service being delivered. And that service, and those CPT codes were limited to about 100 CPT codes. Now, when CTEL began this research, there was no talk of COVID or the public health emergency. And we were conducting this research and efforts to assess data and efforts to remove 1834M of the Social Security Act, where the originating site barriers live. Once COVID happened, we were literally in phase 2 of our research, working hand in hand with Jason and Yael. And we thought, okay, well, maybe this research is all for naught. Maybe it's not going to be useful. But it turned out to be very useful because it was one of the pieces of research that congressionals used and the administration used to continue the public health emergency waivers that included telehealth, and also to expand different licensee groups. Now that telehealth is operating now that the official public health emergency ended on May 11th, and we are operating under the CAA, which is the Consolidated Appropriations Act, which extends those telehealth flexibilities into December 31st of 2024. One of those requirements in the CAA is that there was a need for 2 years of research looking at the post-COVID telehealth costs. And we put post-COVID telehealth costs in quotes because we know that COVID still exists, but the PHE is finally over. And so what does that research show pre, during, and post? And that's the research that CBO needs in efforts for permanency. So we are we would like to work with Jason and Yael, very much like we worked for the first phase of this research study that we presented to Congress in December of 2021. So we would like to work with academic medical centers and hospitals and health systems to donate their data. And we also need to source funding like we did for the first research project in order to compensate Jason and Yael for their time. I'm going to pause here because Jason and Yael could talk about specifically the type of information we need, so we could be efficient about our time, because we only really have to complete this research till May of 2024. So before I hand it over to Jason and Yael, does anybody have any initial questions, or should I, if not, we'll hand it over to Jason and Yael to talk about specifics. Okay, Jason, Yael.
Hey, good morning, everyone, or afternoon, I guess. Jason is going to pull up on his screen a document we put together that goes over the variables that we would need and the standardized format in which they would need them. And he'll help walk through and answer any questions you have specific to those. Jason, you want to share your screen?
Yeah, just give me a second. I'm just looking.
April, can you give Jason access to share screen?
Let me make sure that I.
We know that not everybody could make it to this meeting directly after a holiday, so we are recording this meeting, so feel free to share this with any colleagues that might potentially be interested in participating. And we'll also share with them Jason Yael's follow-up materials.
While I'm looking to get this up, sorry, my computer's just really slow at the moment. The analysis that we would be looking to do, we presented 3 options to Krista, and it really, I think, just comes down to what people would be able to provide to us in a reasonably, I want to say short amount of time, but definitely faster than it was the last time we all were doing this. And then secondly, and I do have to emphasize this, it would just be how much funding we're able to procure. Because if Yael and I are going to dedicate time to this, which we would love to do, by the way, we have to make sure that we're getting reimbursed for that time, because we would be taking time away from other work in which we are getting reimbursed. So as opposed to the last time when we were able to sort of let that slide a bit, and we're just not going to be able to do that this time around, regrettably. So the information is very similar to what we had the last time. I finally got it. Let me just.
You want me to pull it up?
Nope, I've got it. I just need to make sure that I. Okay, can everybody see that? No? Oh, wait. And now?
Yes.
Everybody see this now?
Got it.
Yes.
Okay, great. So as you can see, the information is very similar to what we had the last time around. We've added some additional elements, and the reason for this was twofold. The first is when we did the analysis the first time around, we realized that there were additional elements that we could have used that I think would have made this a bit more robust, and certainly would have helped with distinguishing the types of telehealth that were used, which we were unable to do the first time. And a lot of that is because we were doing that very quickly, and we really needed to pull data to be able to do the analysis to get it ready for Congress to review. The second reason is that, as some of you, if not all of you, know, that we are currently working in partnership with the University of Mississippi Medical Center on a project funded through their Center of Excellence grant from HRSA to develop a national telehealth data warehouse. So a large mechanism by which we would be storing years and years and years of telehealth data, hopefully, in which we would then be able to do this kind of analysis and many others as a result. And so we thought of the new data format in one, looking at sort of what the vulnerabilities or weaknesses were of the original approach, but then secondly, what we would want to have in a warehouse so that as we move into the future and do future analysis, we would be able to pull the elements that we would need to do, you know, the kinds of economic and social science analysis that I think, as I've stated before, has been somewhat elusive over the years. So as you can see, the format here is, again, fairly similar. We're looking at the date of the telehealth encounter, the beginning and end time, the zip code of the originating site, which again would just be the first 3 digits, the claim type, which we did not have before, the classification, the claim frequency. All of these are fairly easily available, should be available from your practice management system and your telehealth platform. The primary diagnosis for the patient, their secondary diagnosis, primary and secondary procedures, prescriptions of medications, their medication history, their laboratory test orders and results. One of them that is, you know, we think is something we're definitely adding is the discharge status. And that way we know, because we don't have identifiers and we're not going to ask for identifiers so we can link patients together. But one of the questions that we did get quite frequently was, after the encounter, you know, was the patient discharged to a hospital or transferred to a hospital rather, or what was their discharge status? And we did not have that information. So we want to make sure that if we're able, we could see if that's something that is we can acquire, the type of insurance that was used, the total charge, which would reflect the total amount of the telehealth encounter itself. And then, as you can see, some, again, some demographic variables regarding the patients, like their age, the zip code, again, which is the first 3 digits, gender. And again, some of this is very similar to what we were doing the last time around. There's about 6 or 7 new elements that we have added. So I'll make sure that Krista has this by today so she can send that around to all of you. The options that we presented to her are, there's 3 of them. So the first, and this, I should back up a minute and say, you know, since we started the work with CTEL, we've done a lot of other economic analysis, both for not large nonprofits like the American Medical Association and smaller companies that have a product or products, as well as for academic medical centers such as the University of Mississippi. So in that light, the options that we presented are, the first one is to basically just do a continuation of what we did in 2021, which was to look at telehealth cost benefit during COVID. And in doing that, we would be asking for a data file starting in January of 2021, all the way up to whatever you have the most recent data that you are able to provide. And then we would basically go through that. We would ensure that it conforms to the format that we've just presented. We would make sure that we have all of the elements that we need. And then we would basically plug it into the models that we developed in 2021. And we would see what the cost benefit was for both Medicare and Medicaid for all of the participants that supplied data. So it would just essentially be what we did the last time around. And it would reflect cost benefit as we were moving out of that initial phase of COVID during the second and presumably third phases of the pandemic into post-COVID. The second option is to do that same cost benefit work, but also to add cost effectiveness to this. So that was something that we discussed some time ago. And because we were really looking to get that data quickly and we had to do a lot of cleaning and organizing with that, we just simply did not have the time or the ability to really delve into identifying the variables needed for that level of analysis. Since that point in time, we've had clients where we have built those models and we have looked at cost effectiveness, which is looking at the various options and determining what produces the best outcome from a cost and health outcome standpoint. So the way we have done it in the past with past clients like the American Medical Association is to look at cost effectiveness from a hybrid telehealth model, which is a combination of in-person and telehealth care, a telehealth only model, and an in-person model. And again, we're not comparing to see which one is better, because as I've said before, I don't think that's kind of a false equivalency. You can't really say one is better than the other, but what's the cost effectiveness of it? So how much do you have to spend to get an outcome that aligns with what the best practice standard would be? So you don't want a readmission to a hospital, you don't want to be hospitalized, you don't want increases in medication, et cetera. So that's what we would be examining. We've done that work. We have the models developed. We need the data. And so what we would do is to look at what the most frequent conditions are in the data that we receive. And then from that, we would then use our models to see what the cost effectiveness approaches would be. Again, across Medicare and Medicaid only. We would not be focusing on commercial payers at this point. The third option is to do both the cost benefit and the cost effectiveness, but then to add on some social science analysis, given that that is really what, at least in our experience over the last 18 months, a lot of people want to know. So what they want to then understand is, how does telehealth utilization affect healthcare outcomes? Does telehealth reduce disparities in care and increase access? And then how can telehealth be used in value-based care models that would generate enough shared savings to incentivize use? We've done that for a couple of clients and are looking actually to do that again with a couple more. And so we've developed these approaches to models really to look at different value-based care programs like accountable care or total cost of care, which is what they do in our home state of Maryland, and identify that if you use telehealth for particular conditions, here are the potential shared savings and return on investment. And if you understand that, then it would be an incentive for providers to be using telehealth and value-based care. So we presented that option as well, that we would do either cost benefit, and cost effectiveness, or cost benefit, cost effectiveness, and then what I'm terming as the social science analysis that would really help with access of care and utilization and disparities and value-based care programs. Now, I do have to caveat this a bit by saying, if it's the third option that everybody wants to go with, and you want us to really do this very robust, in-depth analysis, which we have done parts of this analysis for different clients, we have not done an entire report that completes all of this. So this would be highly innovative and brand new to present this, but we would need data from everybody from January 2019 up until the most current data that you have, because we would have to be analyzing pre-pandemic, during the pandemic, and post-pandemic. The first two options we could just do post-pandemic, but if you want to do that sort of complete analysis, then we would have to have data that's pre-pandemic. Otherwise, we wouldn't be able to get any results that would have any real context or meaning. So, I think it's sort of up to everybody what they'd like us to do. We would obviously, we're thrilled to be asked to do the work and looking forward to doing it. But it just depends upon what everyone would like us to do and how available the data is and how soon they can get the data to us, as well as funding, so that we can then begin the work. Structure.
So ideally, it's a third option that I think would be most beneficial to CBO and to other policymakers. But of course, I will have to determine how much funding that we could gather for this in a very, very short period of time. Does anyone have any specific questions?
Krista, Joe.
Hi, Joe.
Hi. First, well, the two interrelated questions. The first is, what is the probability that we could attract interest and support from industry, the telemedicine companies? And second, assuming for the sake of argument that we could get that support, would we accept it or would we decline it on the basis that the data might then be suspect?
I was thinking about this with a friend of mine who's also in the research field. I think that as long as we continue, well, I'd like to get everyone's thought on this. What if we accepted donations from anyone that would like to provide donations for this research, but we do not share with Jason and Yael, either ever or who funded this, that they do not have it, because Jason and Yael are going to be the team that's putting together this research. CTEL is just simply, I guess, for lack of a better analogy, the general contractor, and Jason and Yael are the team that's actually doing the work. And there's a thick brick wall. Just like last time, the only time that we'll be updated is when we're updated with the entire group, after the research is done or after the methodology has already been designed. Anyone have thoughts on that?
Well, I guess it actually triggers another question, probably the one I should have asked first. Namely, if we went with option 3, do we have any kind of ballpark estimate for what the cost would be?
Yeah, Joe, I sent Krista those costs. I'll let her talk to you about that, I guess, separately, but I worked, priced out what our time would be, how long we think it would be. And I think given the time frame, we'd have to bring on staff, whether that's, I don't think just having interns, which we've started to hire, would be enough. We would probably have to bring on a couple of full-time equivalents to help us with that, to get it done in time.
Okay. Thanks, Jason.
Yeah.
I also wanted to point out that there is a study in Consolidated Appropriations Act that has some of these similar things that needs to be looked at. I haven't heard from anyone in CMS that that's going to come out. So, you know, we just need to think it will come out. It's required to come out. Knowing CMS, it'll come out in 2024 and they'll have 6 months to run the entire study. But just wanted to let everyone know.
I have a question related to that. Is there any, this is Chidema from UCLA, is there any grants available for this work that we've looked into? I think that might be a little bit more sort of favorable as opposed to taking industry money. It tends to sort of muddy the waters a little bit.
The timeline is so tight that we would probably not be within the grant cycle to get those resources and to be able, I mean, we really have basically a little less than a year to put all of this together.
I see.
For health systems that are would be sending data, when would you need that data? What would the deadline be?
We'd probably would need it within 8 to 10 weeks. In that we would have to look at it, we'd have to clean it. If it's, you know, hopefully we would work with everybody that wanted to give data to make sure they were able to match the format so it would reduce the amount of cleaning. The last time we did this, we had to clean a lot of data, which took a significant amount of time. We would like to avoid that if we could. I know that it's impossible to avoid it completely, but we would work with those that are giving data to try to get the format as aligned as possible. And then we would have a cloud-based storage system that we would put it in, a cloud-based database that we would then lock it into, and then we would start the analysis. But just sort of, I'm anticipating that we would have to do some cleaning, some organizing, and some modeling to get it into the database correctly. So that would probably altogether take about 2.5 to 3 months, and then we could start the analysis. So I would say that, you know, at the point that we all decide this is a go, then, you know, between 8 to 10 weeks, we would need to execute the DUAs and start getting the data file.
Jason, Abby would like to see the data dictionary specs. Can you bring them back up on your share screen?
Yep.
Danielle Wesley just said that we'll need the organizational ASAP. Yep, sorry, go ahead. Who's talking?
Because I mentioned several times, but seems like no one can hear me. So my question is, like you mentioned, this is going to be a cost effectiveness analysis, and I wonder what kind of effectiveness you are looking at.
We'd have to ask Jason Yael that question, Dr.
Just
Zhang.
curious.
Jason Yael.
So I'm sorry, I didn't completely hear that question. My apologies.
Oh, because it's going to be, you mentioned this is going to be a cost effectiveness analysis, right?
Right.
And compare pre and post COVID. So I'm thinking like what kind of clinical effectiveness data you are looking at? Because it seems like here mostly going to be the ICD-10 code, the diagnosis. But in terms of the effectiveness itself, what kind of measure you are thinking about?
No, so we would be using, so usually we would be using Markov models and which are the ones we develop for AMA. So the data that we would be getting for the dictionary, or I'm sorry, for the cost benefit analysis, its use in cost effectiveness would be only to identify the most prevalent conditions across programs. And then to, depending upon where we want to focus that analysis. So if we, for example, decide to do 6 states and we want to look at, I don't know, let's say we find a high prevalence of co-occurring mental illness and substance use disorder, for example, we would have to then get that data, those data points for the cost effectiveness from the physician fee schedules for Medicaid and Medicare. And then we would be able to develop, we would be able to input those into the models to come up with this analysis. We'd also then have to model the hybrid approach, which varies depending upon what condition that you're looking at. So rather than just do sort of a broad-based cost effectiveness analysis, which we have done, but we would get a lot more specific by looking into the specific cost elements for specific programs based upon what we find out of this data.
So it depends on what kind of data you can get.
That's correct.
Mhm.
I have no doubt we would be able to get the data we need for the cost effectiveness. It's that the problem is if we do something too broad or too generalized, it will have limited meaning and it will not have any sort of persuasiveness to it when it gets in front of Congress or CBO. It just, they will look at this and like anybody could have modeled this, and they're right. Anybody would have been able to do that. What we would like to do is get far more specific about, you know, in Mississippi, people are suffering from this. If you use these 3 options, you know, here's how cost effective hybrid telehealth is versus telehealth only versus in-person care. Again, not stating one is better than the other, but that, you know, for people that don't have ready access to care for those conditions, telehealth provides a cost-effective option. When we spoke to CBO way back in 2021, this is what they asked us. And we did not have that data at that time to do that analysis. And we had not done the modeling yet that would have been necessary to do it. Flash forward to now, we've done all of that. So it's just, you know, we would want to get very specific about what conditions are prevalent where, find the right elements in Medicare and Medicaid, and then build the model and run it and find out what that analysis provides.
Mhm.
Thanks.
So just to stage set for the last, in terms of funding, we needed to raise $250,000 for the last funding project, and we were only able to raise $82,500. Jason and Yael still completed the project because their commitment to the cause. They won't be able to do that this time. So we will essentially need to raise about the same amount of money, and we'll need to know that probably, Jason, wouldn't you say we would have to have commitment of resources within 8 weeks?
That would, yeah, more than likely. If you need to meet that deadline, yes, absolutely.
Yeah. So We're going to know very quickly if we can do this research or not, because we need, and just as an FYI, CTEL is not receiving any of these resources. Jason and all these resources will go to Jason and Yael and the other researchers to conduct this analysis. This is not a revenue generator at all for CTEL. It's actually a revenue loss for CTEL, because we'll be doing work on this pro bono. But we have to pay the research team. So if you are in a position to have these senior level conversations, we would really like the opportunity to very quickly meet with you and your leadership. Is there anybody that might be interested in having the funding conversation with us or think that it might be possible?
Krista, this is Jasmine, MedStar, for those that don't know me. I have a few questions before I can commit to having that discussion. How confident are we that the methodology that we are leveraging for this project is going to align with what the CBO is interested in seeing?
So this is the methodology we presented to them last time. And they were very much in favor of that. It's also what we presented to Congress and to the White House. There was no issue with the way we approached it. They just asked us for more detail than we were able to provide at the time. So the methodology was viewed very favorably in terms of cost benefit. Cost effectiveness, we presented that to the American Medical Association, who hired us to do that analysis. That was also received extremely favorably. And then the value-based analysis and other analysis that we've done has also been viewed very favorably. Nobody has brought up any issue with this. I think that the question all around is providing more specific detail, which at the time, like I said, we were unable to do. But with this, with the data that were requested, then we should be able to do that.
Understood. And how much added value does private groups like this one and others that I know are looking at developing the same kind of research, how much value add is this over what we know is being asked of different from CMS directly to do some of this work using their own data sets? Trying to determine, is this worthwhile spend, and without trying to be offensive at all, just wanting to make sure that we can understand what is the supposed impact of if we were to move forward with this and provide some funding towards this research.
Well, what I can tell you is this, and it's a perfectly logical question. The value added is that we have not seen, we've been doing this a while now, for almost 3 years. And while we have certainly done different types of analysis in places, I don't think that I have seen something that has really strung this all together and presented this comprehensively across Medicare and Medicaid. There has been analysis that's been done for commercial insurance. There has been some done for Medicare, but there has been very little, if anything, done with Medicaid, which, given that that population uses telehealth services the most, seems to be a little strange. And I think that if there were not a lot of value to this, I don't think that CBO and Congress would be asking for it. CMS seems to be taking very much a wait and see approach. And Yael, feel free to jump in here when I'm done, but I think they're waiting to see how much telehealth is being utilized post-pandemic and for what, to determine how they want to go forward. A lot of that will be very influenced by the CBO, by the White House, and by Congress, which is what Krista's targeting, and rightly so. What we've also seen is that states are going off on their own and doing this independently. That they're not waiting to see what the federal government comes up with, or CMS, that they're doing their own independent evaluations. And even those, which we're involved with, are still not taking this sort of very comprehensive approach that we've proposed, largely because the data is not completely available or they cannot make it available, but because they're only interested in certain facets of this. And so I think when you really look at what people want to know about telehealth, which obviously economically is the desire to understand whether it's feasible or not, is certainly the most pressing issue from a reimbursement standpoint. But secondarily, I think they want to know, does utilization increase prove outcomes? Is there the possibility of overutilization? Does it reduce disparities or does it make disparities worse? Does it increase access to care? And then I think what we found is that if you talk about how this can be used in value-based care programs and understand how it could be appropriately incentivized, that does seem to catch the attention of CMS, because they're pushing all these value-based care programs and they haven't really considered whether or not telehealth would fit into them, except for one model. And that, while it has proven to be effective outside of value-based care, that's really the only one that they're focusing on, where I think telehealth could certainly be a viable option for all of them. But, the devil is in the details here. They want to see just how, effective and valuable it would be. Yael, you have anything you want to add to that?
No, I honestly think Jason's right. CMS is waiting around. I have no idea why. When we've spoken to them, they just don't even know what they're thinking about. ONC released something on telehealth, so they're very interested in it. States are releasing things on telehealth. And so I think, the more information we can get out there, the better. I will tell you, when we spoke to OMB, they would not reveal what their methodology was. We spoke to them and said, here's how we're going to approach it. Do you have any recommendations? They had very few. So we did the analysis the way we said we would do the analysis and shared it with them. They did tell us they were going to use a different methodology, but they wouldn't release it to us. And we said, we understand completely, but just let us know if you think anything we are proposing is incorrect. And they didn't say anything.
I should also say that, all of our approaches are based in past work. So not our past work, but, there have been approaches that have been published in literature. There have been research studies that have been done that are comparable to what we're proposing, but very, very localized, not national. And we are using that methodology and extending it so that it can fit a national framework. So I guess I want to make clear, we're not just deriving these off the top of our head. We are making sure that they are well-grounded and have already been vetted.
I want to insert one thing here. And we brought it up during the first phase of this research, but CBO and certain committees of jurisdiction were being flooded with research that was mostly vendor driven. It wasn't done to the same academic rigor standards that Jason and Yael conducted this research during phase 1 and then hopefully during phase 2. And the other reason that I highlighted that CTEL did not receive resources either in the first or even will be receiving resources in the second phase is that's very, very important to policymakers. The reason that they did not want more well-funded telehealth trade associations to take on this work is because trade associations are really beholden to their vendors, and they felt that that would kind of be a conflict of interest. But CTEL as a research institute that's focused in this area could do it as long as we put up some safeguards in place where there's a thick brick wall between Jason and Yael and CTEL doesn't receive compensation for it. So I just wanted to be very clear about that piece as well.
Could I, this is John, could I offer a potential approach?
Sure.
So this is a very auspicious moment given the debt ceiling limit and the IRA Act and all the negotiating and jockeying that's going on right now for budget. CMS being a major target. And so if you put yourself in the mindset of someone at CMS, they need to be able to develop a narrative around protecting their budget that has two pieces. One is we can do more good And two is we can have a better handle on fraud, waste, and abuse, which is still rampant, really rampant in the Medicare system. And so I would think that if you did a one-pager that outlined how an evidence-based approach to what is legitimately of persistent value post-pandemic, and how your research would help contribute to the detection of fraud, waste, and abuse of misapplication of telemedicine, that you could meet them where they live in this moment of budget negotiations around maximizing value and minimizing risk in their positioning in the budget debate. And while this is not their number one concern in that debate, it could be a plank in their platform in that debate. And I think if you pitched it in those terms to CMS, high enough up in CMS, you would likely get some traction to get direct funding from CMS so that they could, rather than subcontract through CTEL, directly contract with Jason and Yael, who have demonstrated a proficiency at exactly that kind of work. And CTEL could be the sponsor of the proposal, but since it's not taking any financial remuneration from the process, it's in a very perfectly leveraged position to do that. And one of the ways that I would suggest approaching that, if that approach resonates with you, is to go to Mark McClelland at the Duke Margolis Policy Institute and say, how would you, here's what we are proposing, here's what CMS needs, can you help us broker this relationship? And I think you would find a pretty clear path pursuing that kind of approach. And I think funding would cease being an issue altogether because of the significance of of having a credible evidence-based approach for benefit and an evidence-based approach for monitoring for fraud, waste, and abuse, and compliance with those things that are demonstrated to have an evidence basis. That's my take.
So John, thank you. I'm happy to speak to that. First of all, we have a paper that is going to come out. We're just waiting for it to be published on, I think we titled it The Misconception of Fraud in Telehealth. And it provides all of that content, a summary of all of their studies that that OIG and GAO have done, have not found any evidence of telehealth. I'm happy to take the abstract of that, but I don't think I can share that until it's published or I'm violating my publication rights. But basically any white paper, one pager would come directly out of that, the evidence that we've put in there. The other thing is, as far as CMS contracting, CMS has to put it out on the street. It has to be a competitive contract that's legally obligated. So they cannot just give work to anyone directly, except for some small examples, which we would not qualify for. So this would have to be a long procurement process. I do know Mark McClellan. I'm more than happy to reach out to him if he has time to speak with me about suggestions he has. But I suspect CMS is going to be closed mouth because they are required to put something out on the street. And so technically this is a procurement in process, even if they haven't written the scope of work or released it.
Right, and if I could respond to two of the points you made. One, there's no evidence of fraud, waste, and abuse. It doesn't take a lot of imagination to see how that would evolve in a less regulated or in an ongoing unsupervised space. So I think declaring that there hasn't been evidence of fraud, waste, and abuse is valuable, and I look forward to reading your paper. But I don't think that would assuage the fears of congressional leaders in terms of the risk of fraud, waste, and abuse. So I still think there's a political vein to mine in that regard. And then the second issue around the procurement process, I fully understand that and I'm aware of that. But if they haven't written an RFP for people to respond to, you don't have a snowball's chance in the proverbial hell of getting funding that doesn't exist. So what I'm suggesting is that you could stimulate and catalyze their thinking towards that kind of RFP, at which point you could be, I think, a very credible competitor for that work. And the sponsorship of CMS would annihilate concerns about vendor influence and all of those things attending to the bias inflicted by different sources of these analyses. So I'll stop there, but I think there's still an opportunity there.
So would you recommend we reach out to Mark to see if he can broker a conversation? And we have
Yes.
friends at CMS, but reaching out to them directly could be seen as, if a solicitation comes out, it could preclude us from even being on it because we had initial conversations about this.
Well, I would ask Mark about how to bridge that chasm at the same time. So how do you work with him to stimulate an RFP in a way that won't invalidate your ability to respond? Mark is awesome in that kind of thinking, so I would trust him absolutely in that role.
Okay, thank you.
There were a few questions. I'm trying to, I don't know why I've lost Zoom. Anyway, one of the questions was, given the problems that we had getting the data from programs last time around, if we'd done anything to potentially mitigate that, which is also a great question. So I think what we learned is that we need to work when there's an organization that wants to be delivering data. We need to work with them on ensuring that they can map to the format that we've requested. And, you know, I think when we were hands off from it the last time around, that's probably what led to some of those issues that we had to then clean up. So this time around, if the project's a go and we are getting data, then we would work with each of these organizations after executing the DUA to make sure that they're able to map to the format and send us a completed data file. And hopefully that would mitigate some of the issues. We just couldn't be as hands off, I think, as we were the last time. And again, some of that was, you know, we had just started the company, so we were running around with all of the details about, or all of the activities rather, that you have to accomplish to get an organization off the ground. And then the second one is we just needed to get the data and start, because like this project, you know, we were under a very compressed timeline. So we had to work quickly in order to make sure that we were able to get the report done and to CBO and others in a timely manner.
All right, so we'll be following up with the materials that Jason and Yael shared today during our call. Even if you're not a definitive yes regarding providing research and or funding, please just send me an email saying that at least you're interested in, so we could have follow-up conversations. Yael, do you have any comments?
No, just thank you guys for all of your input and suggestions. Again, the more data we get, the more effective this analysis. One of the criticisms we got while the reminder was saying, well, this is not nationally representative. In the states where we had a lot of data, they bought into it more than states where we only had data from certain areas. So the more data we get, the more convincing we can be. We did have 1.4 million encounters, so it wasn't like we didn't have a lot of data. But again, certain states were not as well represented. So we want to be this compelling. We want to make sure that they can't come back and say this is actually not representative of the nation.
Well, thank you everyone that joined today's call. I'll give you back 10 minutes of your hour, and hopefully I'll be getting some emails in my inbox. So if you're going to email me, also include Jason and Yael on the email. If you're going to email Jason and Yael, include me. We just want to make sure that we're all staying apprised of who is interested in participating in this research. All right, guys, thanks so much. Take care. Thanks, Jason and Yael. We appreciate it.
Thank you. Sure. Bye.
Thank you.